Hi, my name is Mastrianni. I'm a PhD candidate at Drexel University. I'll be presenting on our study Transitioning Cognitive Aids into Decision Support Platforms, Requirements, and Design Guidelines. This study was a collaboration between Drexel University and Children's National Hospital. In primary care and inpatient settings, decision support has been integrated into archival systems, like electronic health records and computerized order entry systems. However, in emergency medicine settings, clinicians often use archival systems after the medical event. As a result, integrating decision support into these archival systems may result in the decision support being provided too late in the provider's workflow after the event has ended. In contrast, digital cognitive aids like checklists are implementation tools specifically designed to be used by the clinicians during the medical event. Because these tools are being used by the clinicians during the event, decision support features could be integrated within digital cognitive aids. In this study, we examined how a digital checklist used during pediatric trauma resuscitation could provide decision support for identifying and treating patients with severe blood loss. Pediatric trauma resuscitation is a time-critical medical event where a team of clinicians evaluates and treats a child who arrives at the emergency department with traumatic, life-threatening injuries. The team leader guides the team through the resuscitation process, which consists of a primary survey, where the team evaluates the patient's airway, breathing, and circulation, and a secondary survey, where the team assesses the patient head to toe for any other injuries. Since 2017, team leaders at our collaborating research site have used a digital checklist implemented on a Samsung Galaxy tablet during trauma resuscitations. The checklist lists the tasks that should be performed by the team during the resuscitation. There's also a space at the top of the checklist called the margin note area for the leaders to take any handwritten notes about the case. We examined how the digital checklist could support two types of decision support alerts. The first alert identifies patients at risk of severe blood loss. The second alert helps to mitigate delays in establishing IV access, which is required for administering blood transfusions to patients. To function as a decision support platform, the checklist would need to obtain the data required for determining the appropriate decision support for the case and communicate this decision support to users. In this study, we focus on the first component, obtaining the information needed for determining the appropriate decision support for the case. Our study had three main phases. In the first phase, alert requirements, we identified the types of design changes needed to transition cognitive aids from task lists into decision support platforms. We analyzed checklist notes from 154 past cases to identify the types of information being captured by the team leader. We also conducted a retrospective analysis of 76 cases to understand if using the task status documented on the checklist would allow for accurate alerts about delays in establishing IV access. In the second phase of the study, we conducted co-design sessions with 8 team leaders to design new features for the checklist to improve the acquisition of data needed for decision support. We used these findings to develop 2 new features for the checklist, which we refined through near-live simulation sessions with team leaders. We then released these features on the digital checklist at the hospital, studying how clinicians use the features to document context information and task status during 139 resuscitations. In our alert requirements phase, we examined handwritten notes taken by team leaders in the margin area of the checklist during resuscitations. These notes contained information that could be used to determine the patient's risk of severe blood loss, such as their age, mechanism of injury, consciousness scores, and vital signs. However, the notes were not always taken in a standardized manner and did not always include all variables. We also examined if we could use the task status of the established IV access task on the checklist to determine and send alerts about delays in establishing IV access. We examined 76 past resuscitations, using the presence of delays in establishing IV access in the case, and the status of the IV access checklist task to determine if the case would have a true alert, missed alert, false alert, or true non-alert about delays in establishing IV access. We found that alerts would not have been triggered in most of the cases with delays in establishing IV access because team leaders were checking off this task on the checklist before it was actually completed. To design new features to improve the acquisition of data needed for decision support, we drew on findings from co-design sessions with 8 team leaders. In these sessions, participants were asked to identify current issues with the checklist and sketch potential solutions. Several leaders sketched a new feature for capturing patient context information shared by emergency medical services before the patient's arrival at the hospital. Participants noted that they often handwrote this information in the margin note area of the checklist, highlighting several benefits to having a form for structured entry. First, participants thought that clicking through the form would be faster than handwriting the information. Second, they envisioned viewing and using the information to prepare for the case. For example, one participant noted that identifying that the patient was not restrained in a car accident could prompt them to think about needing a C-spine stabilization collar for the patient. Third, participants noted that the pre-hospital information entered in the form could then be used to adapt tasks on the checklist or support decision-making by suggesting different algorithms. We drew on these findings to develop a pre-hospital form that would automatically open when a leader started a new checklist. The leader could then use this form to enter the patient's age, mechanism of injury, symptoms, and treatments, all information that could be used also to determine the patient's risk of needing a blood transfusion. In these sessions, participants also highlighted that unlike other tasks on the checklist, the task to establish IV access required multiple steps. Nurses had to place a tourniquet on the patient's limb, successfully insert a needle into the patient's vein, and confirm that the IV placement was successful. The checklist design only allowed team leaders to mark 2 types of task status: not started and complete. Because the IV access task had multiple steps, we explored using a progress slider for the task instead of a checkbox, which would allow leaders to mark 3 types of task status: not started, in progress, and complete. After we used the findings from the co-design sessions to develop these 2 new types of features, we conducted near-live simulation sessions with 4 team leaders to refine the features further before we released them on the checklist at the hospital. After releasing these features on the checklist at the hospital, we studied their use in 139 resuscitations. Clinicians used the pre-hospital form during 85% of cases. The graph shown here compares documentation rates for the different variables between the checklist with just the margin note and the version of the checklist with the pre-hospital form. As you can see, the pre-hospital form increased documentation of variables needed for identifying patients with severe blood loss. But some variables, like age and injury type, were documented more frequently than others, like the consciousness score, heart rate, and blood pressure. We reviewed videos of the resuscitations with pre-hospital form use and the pages sent to the resuscitation team by emergency medical services before they arrived at the patient. We have found that these pre-arrival pages infrequently included vital sign information and would provide classifications such as normal vital signs instead of exact values. In general, leaders often managed uncertainty and incomplete information when using the form, receiving information both through pages sent by EMS before their arrival and in the report verbally given by EMS once they arrived at the patient. We observed that leaders would re-access the form to correct information, but not to enter new information. We also examined how the proportion of true alerts, missed alerts, false alerts, and true non-alerts would have changed, as the design of the IV access task on the checklist switched from the traditional checkbox design to the progress slider design. Using the progress slider instead of the checkbox would have reduced missed alerts in cases with delays in establishing IV access. However, this design change would have also led to more false alerts in cases without delays in establishing IV access. From our study, we contribute several design guidelines for transitioning cognitive aids into decision support platforms. I'll begin by discussing the design guidelines for supporting alerts about treatment decisions. First, structured data entry could be used to capture the context information required by decision support algorithms. Second, because clinicians may not always have exact values for patient measurements, options could be provided for entering or selecting classifications, such as normal vital signs, especially if the decision support algorithms do not require precise values. Third, because team members may arrive to the medical event at different times, other team members could be allowed to document information within the checklists or view information that has been documented by the user. Since we conducted this study, we developed a new display in the trauma resuscitation room that showcases the information entered in the pre-hospital form to help team members gain situation awareness if they arrive later in the event. Finally, because of the dynamic nature of medical events, the checklist features should support documenting data at multiple times throughout the event. Next, I'll discuss guidelines for supporting alerts about mitigating delays in task performance. First, our slider had 3 stages: not started, in progress, and complete, representing the task status. But these stages could have different meanings to different users. Some users may consider the task as in progress when they've instructed the team to start performing it, while others might consider it as in progress when the team starts the first step of the task. An alternative approach to using task status as the stages in the slider could be to put the specific subtasks, like perform venipuncture in our case. Clearly defining the task stages represented on the cognitive aid could reduce ambiguity and improve decision support features related to delays. Because the progress slider was in one section of the checklist, users in our study would scroll away from the slider as they moved to other sections. Locating the slider in a global view, where users can continuously change and view its status, could have increased the accuracy of the slider. After task completion, the multi-step task could be removed from the global view to reduce the amount of information showed to the user and focus their attention on the other tasks that need completion. Finally, false alerts are detrimental in safety-critical domains, as extra work is required to distinguish true alerts from false alerts, which can erode a user's trust in the alerts. Because the design of the checklist item, such as a checkbox versus a progress slider, can impact the proportion of missed and false alerts, designers should consider the implications of false and missed alerts when designing the cognitive aid features. In situations where the user can easily assess an alert's accuracy, feature designs that lead to more false alerts, but also more true alerts, may be more acceptable. I'd like to conclude by thanking the clinicians at Children's National Hospital for participating in this research. We'd also like to thank our funders, which include the NIH and NSF.